I'm Dr. Terry Moore, and I'd like to thank RheumaCon 2021 for inviting me, Dr. Rashid and Dr. Mahmood. I'm going to talk today on a topic that I've written many papers on. It's a kind of a basic talk with some of evaluation of labs in connective tissue disease. Laboratory studies in connective tissue disease can help depict what the specific diagnosis is, and now with our new laboratory studies, it helps us in defining the disease and maybe which organ systems are mainly involved. When we start the original studies, we always want to do baseline studies so that we have these for the future when patients change, activities change, and other things happen. This outlines the basic laboratory tests that we should do and baseline for all patients: the CBC, urinalysis, sedimentation rate, C-reactive protein, the comprehensive metabolic panel, and muscle enzymes. The CBC is going to show us, again, possibly the anemia of inflammatory disease. It also may show an acute hemolytic process, which we may see in some of our patients with lupus and Sjogren's. It may show a low white count or a high white count. Low white counts are very important because one of the most common causes of leukopenia or low white count and low platelet counts are our lupus and Sjogren's patients, especially our young females. General inflammation, we're going to evaluate for sedimentation rate and C-reactive protein. These will tell us if there is any kind of inflammatory response. Usually we see in patients with rheumatoid arthritis, lupus, elevated sedimentation rates. However, with the patients with scleroderma and dermatomyositis, these acute phase parameters may be normal. The sedimentation rate in children should be less than 5 millimeters per hour by modified Westergren, and in adults less than 15. The C-reactive protein should be less than 0.3 milligrams per deciliter. There is no association with age as previously described. Urinalysis is fairly obvious. The proteinuria showing glomerular damage, which we may see with lupus. We may see renal tubular acidosis in some of our young Sjogren's patients, especially we've seen this in some of our young medical students. Also, white cells, and red cell casts are obvious to show renal damage. And if there is abnormalities, we're going to go on and collect a 24-hour urine or a creatinine total protein ratio, and we will proceed on for a renal biopsy if there is any worsening of the disease. The comprehensive metabolic panel is fairly obvious: increased creatinine showing renal disease and lupus, liver enzyme abnormalities for hepatitis or medication toxicity. We always want to measure all three muscle enzymes, CPK, aldolase, LDH. In adult patients with myositis, most are all elevated, but in children, one of the three may be. We may also want to evaluate macrophage function in these patients with myositis with neopterin and von Willebrand's factor antigen levels. One of the keys which we see missed by many internists, pediatricians, and family practitioners is looking at the albumin-globulin ratio. This should be albumin of 4 and a globulin of 2.5. When this ratio approaches 1 or less than 1, this shows us that there is increasing globulin formation and indicates a possible underlying connective tissue disease. The general studies to define the diseases are outlined here. We use the rheumatoid factor, anticyclic citrinated peptide antibodies, and ETA proteins, the antinuclear antibody, which the positivity causes more consults for us than any other test. And we will always evaluate complement levels, antiphospholipid antibodies. We will talk at the end on ANCAs and cryoglobulins. Rheumatoid factor is a classic IgM molecule. It, however, is found in all immunoglobulin classes. However, in rheumatoid arthritis, we're majorly measuring IgM rheumatoid factor. It is an anti-IgG globulin against the Fc fragment of IgG. If you can measure both IgM and IgA rheumatoid factors, this will indicate more severe disease. Most labs now do the ELISA technique, so anything greater than 20 and usually over 40 international units will be specific for rheumatoid arthritis. Rheumatoid factor is a pentamer, as seen here in this diagram. It has the affinity for forming immune complexes. Because of the hit binding sites, it will form a 19S IgM and 5,7S IgG molecule to form the immune complex that we see mainly in rheumatoid arthritis patients. The principle is an enzyme-linked immunosorbent assay. You will load, it is loaded to assay. You load the IgG on the test tube. You add the patient's serum, add a conjugated enzyme, and you add enzyme substrate to measure the optical density. Again, usually greater than 40 international units will be positive. Rheumatoid factor, however, is not specific for rheumatoid arthritis. It is a non-specific IgM antibody response to an external antigen. We do see it in our juvenile arthritis patients, most likely polyarticular in onset in about 30% of the cases. It is present in about 80 to 90% of patients with rheumatoid arthritis, but is also present in about a third of patients with lupus, scleroderma, mixed connective tissue disease, and polymyositis. It, however, is noted that those patients with connective tissue disease that are positive for rheumatoid factor may have a higher incidence of joint complaints. It's also a very high percentage in patients with Sjogren's. It also, again, a non-specific response. It will be transiently positive in patients with a history of Epstein-Barr virus, CMV, parvovirus, hepatitis B and C. I write the section on up-to-date on viral arthralgias, and you can detail some of the information there. As all antibody formation, rheumatoid factor in extravasated fluid can be increased in concentration, and can be found in synovial fluid, pleural and pericardial fluid. When found in these extravasated fluids, it may be more severe disease. One of the things that we now know is that antibodies to cyclic citrullinated peptide antibodies are antibodies reacting with the synthetic peptides containing the amino acid citrulline. It is the most translational modified arginine residue. It is very specific for rheumatoid arthritis and found in about 75% of adult patients with rheumatoid arthritis and in about 20% of children with juvenile arthritis. It can be found in all immunoglobulin classes at the onset of disease, and those that have all three antibodies may be more aggressive. Anti-CCP antibodies have multiple citrullinated epitopes. Multiple of our studies in our lab have shown that there are antibodies to fibrinogen, vimentin, alpha-enolase, filaggrin, type 2 collagen, and histones. And this can be recognized in both adult rheumatoid and juvenile arthritis patients. Those patients with multiple anti-CCP epitopes may have more severe disease. A newer antibody, which we have reported in juvenile arthritis and other groups have reported in RA, rheumatoid arthritis, is anti-carbamylated protein antibodies, anti-CARP-P. Carbamylization or homocitrulination of lysines is a post-translational modification. And this occurs spontaneously through a reaction with a cyanate-mediated myeloperoxidase. Anti-carbamylated protein antibodies are known to prevent joint damage and precede the onset of rheumatoid arthritis, and therefore may be a forerunner of more severe disease. These are not readily available in most labs, but can be obtained. And lastly, some studies that we've done and some other groups have shown that the 14-3-3 eta proteins, which are ubiquitously expressed intracellular chaperones, this ETA isoform is uniquely expressed in the synovial fluid and serum patients with rheumatoid arthritis inflammation. It also can sometimes be helpful in patients with psoriatic arthritis who have all other studies negative. It is a protein that can be found in adult rheumatoid arthritis patients and polyarticular JIA and shows a more severe disease. The test that is most not understood in evaluation of patients with connective tissue disease is antinuclear antibodies. These are a diverse collection of antibodies directed against numerous macromolecules, which are normal constituents of the cell nucleus. The presence of an ANA is a hallmark of connective tissue disease, but not diagnostic. Low titers, less than 1 to 3 20 can be found in 30% of the healthy female population, more of an estrogen effect. So to define if a positive ANA is present, a ANA profile should be run. Again, viral infections such as EBV, CMV, and parvovirus can cause a transiently positive ANA. Also, we see 4 or 5 times a year patients referred to us with a positive ANA, and they have underlying autoimmune thyroiditis. Antibodies to TPO and thyroglobulin can cross-react and cause positive ANAs. The significance of the ANA is that it can screen patients for connective tissue disease, but the specific antibodies that make up this can give evidence of possible organ systemic involvement or disease course. Rising and falling titers of ANA are not associated with disease activity, but certain specific antibodies, such as antibodies to double-stranded DNA and antibodies to RNP, can correlate with disease activity. The most widely used technique in the world for the detection of ANA is the indirect immunofluorescence using human epithelial cells as a substrate. The standard has an adequate abundance of the routine antibodies, double-stranded DNA, single-stranded histones, SN, RNP, SCL70, and SSB, but it has very low concentration of SSA, and also it may not pick up cytoplasmic antigens, such we'll discuss, such as ribosomal P and the anti-synthetase antibodies. Immunofluorescence is using this human Hep2 cell substrate. Serum is added. We then add a fluorescent labeled anti-immunoglobulin, and 5 types of patterns are seen. 1, the rim pattern, which may be seen in lupus and dermatomyositis. Homogeneous pattern, which is a diffuse pattern making up a multiple as well as speckled. And the nucleolar pattern, which is mainly seen in patients with scleroderma. Also, the discrete speckled pattern, or the anti-centromere pattern, is mainly seen in patients with scleroderma. If ANA again is positive by Hep2 cell substrate, or there's a high suspicion for autoimmune disease, you need to order an ANA profile, which will give more definitive information. It includes most of the antibodies as listed here, and to some lesser antibodies. If we go through the different connective tissue diseases, which antibodies are the important ones? Antibodies to double-stranded DNA occur in about 75% of lupus patients. It correlates with renal disease, central nervous system disease, vasculitis, and low complement levels. It usually will give a homogeneous or rim pattern on the ANA, but you need to be evaluated by ELISA or Crithidia. There are 2 assays for antibodies to double-stranded DNA. Crithidia lucilia is very specific for double-stranded DNA, and high titers are very specific for lupus and can correlate with disease activity. The ELISA assay is more sensitive, but it can also give cross-reactation for single-stranded DNA. High titers are very specific for lupus, but low titers can be seen as cross-reactive antibodies, such as patients with hepatitis B, C, certain now biologics such as Humira and Remicade may cause low levels of antibodies to double-stranded DNA by ELISA, and again, some drug-induced syndromes. Other autoantibodies that are important in the evaluation of lupus include antichromatin. The combination of antichromatin and antibodies to double-stranded DNA can be very specific for a diagnosis of nephritis. It also, chromatin and antibodies to histones can, as seen alone, can also be possible drug-induced syndromes, which we will see with oral contraceptives, propylthiouracil, and many of the ADD medications. We wrote a paper a couple of years ago detailing the antibodies to histones and chromatin that occur with ADD medication. The more specific antibodies for lupus, and as in the criteria for lupus, is antibodies to SM, and it occurs in about 30 to 40%. It is important because this is the antibody that correlates with pleural or pericardial disease. Also, antibodies to URNP also, as we will show, is specific for mixed connective tissue disease, but in combination with other antibodies, again, it correlates with mild disease, Raynaud's, and restrictive lung disease. So anybody with antibodies to SM or RNP at onset need baseline echocardiograms, pulmonary function tests, and these need to be monitored yearly or every 2 years, depending on the involvement. Other specific antibodies for lupus include antibodies to SSA and SSB, which are the a correlation with Sjogren's. It correlates with subacute cutaneous lupus, the neonatal lupus syndrome, and these are the antibodies that can cross the placenta and cause neonatal lupus syndrome. These patients most commonly have SICA complaints. They're also a high association with partial C2 and C4 deficiencies. As stated previously, the ANA can be negative with some substrates with high titers of antibodies to SSA. So if patients are suspected of possible Sjogren's or lupus, these should be assayed strictly. Antibodies to SSB usually also correlate with neonatal lupus and are usually found in combination with antibodies to SSA. If SSB is alone, you have to think of some types of lymphoproliferative disease underlying it. Lastly, in lupus is the one antibody that we do know correlates with central nervous system disease. This is antibodies to ribosomal P. It correlates with CNS vasculitis and cerebritis, and it also may see a high incidence of psychosis in these patients that have this antibody. It is not a nuclear antibody, it's a dense cytoplasmic, and so your person reading these slides has to be very careful in assaying that. One of the other antibodies that can be ordered in certain labs is anti-C1q antibodies. These are antibodies that react with the first component of complement, and they have shown significant correlation with active renal disease, proteinuria, and urinary casts. And a combination of antibodies to histones, chromatin, C1q, and double-stranded DNA indicate very more severe renal disease. Antibodies autoantibodies to U1RNP are the specific correlation with mixed connective tissue disease. These antibodies occur in 99% of those patients. If they are alone, antibodies to RNP, the diagnosis can be made of mixed connective tissue disease, but many times these patients evolve into lupus patients long-term wise. It correlates with Raynaud's, myositis, and again, restrictive lung disease. So again, patients with these antibody formation should have pulmonary function tests and echo every 2 years. Autoantibodies in Sjogren's syndrome occur in about 90% of patients with Sjogren's. These are antibodies to our SSA or Rho, or antibodies to SSB and La. They're associated with, again, positive rheumatoid factors, leukopenia, low platelet counts, and increased immunoglobulin levels. So patients with these antibodies, again, immunoglobulin levels should be monitored. Also, about 7% of patients may go on to develop lymphoproliferative disease. Again, these are the antibodies that can cross the placenta and cause congenital lupus syndrome. Recently, there has been development of those patients that are negative for antibodies to SSA and SSB, may be seen in 10% of the patients. Minor Sjogren's antibodies are noted. They are salivary gland protein, SP1, carbonic anhydrase 6, and parotid secretory protein. These should be analyzed early on, and they may help in identifying patients at earlier stages of disease. Now, if we're trying to evaluate patients with autoimmune myositis, we have the classic dermatomyositis, polymyositis, overlap myositis, necrotizing autoimmune myositis, and inclusion body myositis. There are a multiplicity of autoantibodies found in patients with dermatomyositis and polymyositis. The most common is antihistidyl tRNA synthetase, or JO1, occurs in about 40%. The others occur in smaller percentages, but are very specific for a diagnosis of myositis. The most frequently detected, as I alluded to, is the anti-JO1 is the most frequently found. It is an antibody that also is associated with restrictive lung disease, and so pulmonary function tests should be checked at baseline. There are also other myositis, such as anti-PL12, anti-KS, and OJ, which are associated with interstitial pneumonitis, and therefore these patients need their lungs monitored. These patients also have arthritis, fevers, Raynaud's, and many of these patients have what's called mechanic hands and have the classical dermatomyositis findings of Gautrins, papules over the MCPs, and a heliotrope rash over the eyelids. Histopathologically, they demonstrate prominent perimesal inflammation and myopathic changes. The other antibodies that we see are as outlined here. These again have, to a less extent, smaller percentages, anti-signal recognition particle. The one thing we do know is that you can have antibodies to anti-HMG-CoA synthetase. These are the patients that may have a resulting myositis secondary to statins. So if there is a statin thought that the myositis is due to statins, the HMG-CoA synthetase should be measured. There are novel specific autoantibodies in adult polymyositis and dermatomyositis that have been designated over the last couple of years. Anti-MDA5 or anti-KEB1 is seen in patients with skin lesions, but mild muscle involvement. However, interstitial lung disease is prominent, and so again, close follow-up with chest x-rays, pulmonary function tests, and CTs. An antibody to SAE also shows a lot of skin lesions predominant, and anti-TIF1 gamma is a severe skin lesions, and in adult patients, there's an increased risk of malignancy with patients that have this antibody. And lastly, anti-MI2 antibodies occur in about 20% of patients with dermatomyositis. It is an antibody that is associated with classical skin involvement and milder muscle involvement. Autoantibodies in systemic sclerosis occur in almost all 100% of patients. By far, the most common antibodies are antibodies to centromere, which we will see in limited scleroderma and produce the discrete speckled pattern. We also see antibodies to topoisomerase, which is antibodies to SCL70, and this is seen in patients with diffuse scleroderma. Lastly, the third most common is anti-RNA polymerase 3, which is seen in about 20% of the patients. Usually they have diffuse symptoms, but the importance of this is that about 1/3 to 1/5 of these patients may have an underlying malignancy. Other antibodies seen in lesser extent are antibodies to U1-RNP, like we see in mixed connective tissue disease. Antibodies to PMSCL are antibodies that we see many times in younger patient populations. They have an overlap of scleroderma and dermatomyositis-like symptoms. However, long-term wise, they have a very good prognosis. The others, anti-TOE, anti-fibrillarin, anti-high nuclear RNP, can be found in diffuse patients. Therefore, if you think scleroderma, the clinical findings are associated and they do not have one of the three top antibodies which can be readily assayed, you need a scleroderma panel to determine if there is an underlying antibody formation. So overall, the specificity of the anti-nuclear antibody, patients with lupus, antibodies to double-stranded DNA, SM and RNP, SSA and SSB determine that this is a diagnosis. Again, antibodies to double-stranded DNA are associated more with central nervous system and renal disease. Antibodies to SM and RNP with more pleural and pericardial disease. Antibodies to SSA and SSB are a more milder disease. However, they more have sicca complaints, and these are the antibodies that can cross the placenta. So any female with these antibodies and pregnant is a high-risk pregnancy patient that needs to have ultrasounds almost every 2 to 4 weeks during the pregnancy. Antibodies to RNPs by itself are a diagnosis of mixed connective tissue disease, but again, following pulmonary and echocardiogram. Scleroderma, again, the antibodies to centromere, topoisomerase, or antibodies to SCL70 and RNA polymerase 3 are of vintage. Polymyositis, again, the antibodies that we outlined, and the antibodies to Sjogren's. Lastly, we will go over these studies that help us in sometimes monitoring disease activity. All these diseases are immune complex in nature and therefore fixed complement. So we can look at classical mouse-binding lectin and alternative pathways. These are the classic picture of antibodies, classical pathway, which is immune complex, fixes C1q, C1s, C1r, C1s, then fixes a C4, C2, and then goes through the terminal components. We take advantage of this in measuring complement components. We normally at baseline will measure C3, C4, and CH50. The CH50 is a screen to rule out complement deficiencies, less than 60 mean. We also will measure C3 and C4. C4 is the most sensitive to minor episodes of complement activation, so long-term monitoring of C4 may help in looking at diagnosing disease activity. 0.9% of the population has a partial C4 deficiency. Also, C2 may be measured, and 1.9% of the population may be partial C2 deficiencies. The deficiencies of these two molecules have a high incidence of developing a connective tissue disease down the road. C4 deficiency, if you measure allotypes, if you have complete deficiencies of C4A, it has a high incidence of developing lupus. C4 deficiencies, B deficiencies, more infectious etiology. Heterozygosity for C4A or C4B also leads to connective tissue disease, and about 50% with C4A and 20% with C4B. Other studies that should be measured at baseline include antiphospholipid syndrome antibodies, the anticardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein antibodies. Most commonly, the antibodies are associated with more clotting abnormalities, migraine headaches, and miscarriages in families is the IgG antibody. Therefore, these all should be measured at baseline. Again, careful evaluation of your patients. If there's any history of migraine headaches, miscarriages in the family, these should also be formed at baseline. One thing too also is if there is any evidence of peripheral vasculitis, skin changes on the hands or feet, cryoglobulin should be measured, but it's very careful to measure these because you can get a lot of false negative results. The tubes and the syringes should be equilibrated at body temperature 37 degrees before drawing blood. After drawing, immediately place the blood in the 37-degree water bath for clotting. The tubes are then centrifuged at 37 and the serum aspirated, and you observe it at 4 degrees for up to 10 days. You may see a white flocculation. The association of cryoglobulins is very high with peripheral vasculitis, peripheral nerve involvement, and immune complex disease, and therefore vigorous treatment needs to be performed in these patients with positive cryos. The cryos are in 3 areas: monoclonal, mixed, and polyclonal. The ones we see most with our connective tissue disease are the mixed and polyclonal. Monoclonal are usually more in the history of lymphoproliferative diseases. Mixed cryos almost always have a rheumatoid factor component to their complex. Lastly, we'll just mention that recently we've seen a lot more younger patients with ANCA-associated vasculitis. The way to measure that is to look for anti-neutrophil cytoplasmic antibodies. These are present in about 90% of patients with granulomatosis with polyangiitis, the old Wegener's granulomatosis. Also, microscopic polyuritis and inflammatory bowel disease may have these antibodies. They come in 2 cytoplasmic and nuclear. Cytoplasmic antibodies are seen in basically with proteinase 3. And these are antibodies to proteinase 3. They're seen in 90% of patients with GPA, and it does correlate with disease activity. These levels may rise and fall. Perinuclear ANCA is antibodies to myeloperoxidase, which we will see in eosinophilic GPA, such as the old Churg-Strauss, microscopic polyuritis, IBD, and drug-induced syndromes. You do see such drugs as minocycline and propylthiouracil that can produce these antibodies. So overall, what I've tried to do is outline what labs we'd like to see at baseline. They help in diagnosis. They help in also knowing what organ systems may be involved in the future and how to perform other assays, such as going on to renal biopsy, make sure monitoring pulmonary function tests and echocardiogram. And again, antibodies to double-stranded DNA, antibodies to RNP may correlate with disease activity, and ANCAs also correlate with vasculitic disease. If there are any questions, please, this is my email, and I appreciate the honor of being able to give this to RheumaCon 2021. Again, I thank Dr. Rashid and Mahmoud for asking me this, and if there are any other questions, please email me. I thank you very much. Thank you.